Good afternoon, everybody. I'm actually standing in for Dr. Virendra, who is our radiologist with us, interventional radiologist. He's been busy with a case, so thank you. So one thing we all know as interventionists is that manual compression performed properly is the gold standard for achieving hemostasis at the end of a procedure. So then the question arises is why do we need vascular closure devices? Well, necessity is the mother of invention. That is the cause for the development of the vascular devices. So do we have enough reasons? Well, all of us here want our patients to have early hemostasis from the access site. We want our patients to be ambulated early. We want to improve the comfort. We don't want them lying down for 6-8 hours without moving their limbs. We want to improve their satisfaction. In high output centers, we need increased patient throughput. We don't want the daycare to be jam-packed with patients who had their procedures and are lying there waiting for hemostasis. In the drug-eluting era, in the stage of stents, drug-eluting stents, we do not want to interrupt the dual antiplatelets. Obese patients, we all know manual compression is difficult. And with the increasing trend towards a total percutaneous approach for endovascular procedures, vascular closure devices are a necessity today. So does data support vascular closure devices? Well, the data is limited. I have a few meta-analyses. Frederick et al. In 2001, he has stated very clearly that patients who receive GP2B and 3B antagonist during interventional procedures, the use of vascular closure devices was associated with a greater protective effect than in patients not receiving a glycoprotein inhibitor. In another meta-analysis by Vaticus et al., he has also stated that angioseal and perclose were associated with a reduction in the risk of major complications. So we come to the vascular closure devices. Do we have them? Are they easily available? Well, we have almost over 20 products available off the shelf. So broadly, I can classify them in 3 groups. We have the active approximators. These are the ones that achieve a physical closure using either a suture, a clip, and the sandwich technique. We have passive approximators. These are the ones which have sealants or gel at the arterotomy tract and then manual compression. And then we have certain novel devices which are coming in which simulate manual compression or create a short intramural tract to achieve hemostasis. So coming to active approximators, we have 3 types again. A collagen footplate device, for example, your AngioSeal, your suture-based devices like your Perclose ProGlide, your ProStar, your SuperStitch, and your Excite. Your clip and staple-based devices, excuse me, like your StarClose XC, your AngioLink. So let me talk about first the AngioSeal, which is one of the most widely used vascular closure device. It has 3 components, your anchor, your collagen, and your suture, all of which get absorbed within 60 to 90 days. The biggest downside of this is that there is a foot plate which is intravascular. So there is always a risk of dislodgement with distal embolization. The collagen part gives you a chance for infection and there can always be a foreign body reaction. Re-entry again is a major problem because there is a foot plate, so they recommend that you re-enter at least a centimeter below or above the previous puncture. So this is a small video which will demonstrate how an AngioSeal is used. Can I please run this video, please? So after removal of the sheath, you introduce the sheath of the device. You see the blood coming out, remove the obturator, introduce the device, the footplate deploys, and you withdraw the device, and with it, you deploy the collagen plug. And thereafter, we get complete hemostasis. The next that we will talk about is the most popular of its category, and that is the suture-based device, that is the Perclose ProGlide. The best advantage is that it gives you a true surgical knot. As a vascular surgeon, I know what a true surgical knot is. So it really gives you a true surgical knot with complete tissue apposition, the only downside being that there is a learning curve. There is a definite learning curve, and it can be used for devices or for sheaths from 5 French to 8 French. This is a small video demonstrating how we use the Perclose ProGlide. It is all numbered 1, 2, 3, 4, 5 steps. You introduce the ProGlide device, deploy the footplate, capture the wires or threads in the intravascular region, pull out the threads, and there's an inbuilt cutting device. You cut the thread and you remove the device after recapturing the foot plate. So you get 2 threads. Please make sure do not use the thread with the white wire or the white end behind. Just tighten the one which is the blue thread and pull it. You get the approximation of the knot. Slide it down, push it, confirm the knot is there, hold both the wires then, and cut it. The next is ProStar XL. It is also a suture-based device. It's for larger holes. The advantage is it has about 4 needles in place of the 2 which are present in ProGlide. It also gives you a true surgical knot with complete tissue apposition. The only disadvantage, which is the downside, the largest and the biggest downside, is that it has a very long learning curve. It's a pretty complicated procedure. So, but it is useful for larger holes, and with the advent of the decreasing size or the decreasing profiles of the interventional procedures, as sheaths and the devices, we can start using ProStar XL much more. StarClose is a popular device in the category of the clip-based devices. It is a nitinol clip which is kept above the arterotomy. Nothing is intravascular, which is the best advantage for it. The biggest downside is that some people do have a nickel titanium allergy and they can get allergic to the clip, and artifacts may be present on CT and MR angiography. Then we come to passive approximators. These are sealant or gel-based, which are Exoseal and Minx, and you sometimes even have bioabsorbable plugs, not yet available in India. Exoseal is a polyglycolic acid plug. It is completely extravascular, reabsorbs within 60 to 90 days. The best advantage is it utilizes the same sheath as you have used for your interventions or diagnostic angiographies. So you can use it in your 5, 6, and 7 French sheaths. So this is a small diagrammatic representation. The device clips onto the pre-existing sheath. You watch for this. Actually, there are these markers there. When you withdraw the device along with the sheath till you get a complete black mark. Once you get that, you deploy the device and you remove the whole thing along with the pre-existing sheath. Minx is another device, unfortunately not yet available in India. It is a polyglycoethylene plug, completely reabsorbed in 30 days as compared to Exoseal, which get reabsorbed within 60 to 90 days. Again, you can use it through the same sheath. Then there are certain novel technologies which are coming up, like your boomerang, catalyst, Xera, and your fish. The boomerang and the catalyst, they depend on the boomerang effect, the recoil of the artery causing closure of the puncture site. That again uses the same existing sheath. There is no need to upsize the sheath. The only problem, which is at present the biggest disadvantage, is that for a diagnostic procedure, this device needs to be in place for about 15 minutes, and for a therapeutic procedure or an intervention, you need it to be kept for 2 hours. Xera is a device which is used at the beginning of the procedure. You enter these, it's a standard arterotomy at 45 degrees. You use the Xera device. So your standard thing comes here. Xera creates a tunnel like this. So this causes a longer, shallower arterotomy. So the thing is that at the end of the procedure, when you remove your hardware, just simple compression over the thing causes severe overlap, and that causes early hemostasis in these patients. You have also got hemostatic patches which you can introduce into the arterotomy tract and then apply manual compression over them. So the question arises, do we have a perfect device? Well, the answer is no. I'm sorry. As of today, we do not have a perfect device. We still strive for perfection, and the device that will allow us early ambulation, improved patient comfort, effectiveness on anticoagulation, and has no complication will be the perfect device. So what are the qualities of an ideal closure device? It should be easy to use. It should not be difficult. It should not be there must not be too many steps, not too much complications. It should be easy to be used even by beginners. There should be no failures, ideally no failures. In case a device failure does occur, it should be immediate, not after 5 hours or 6 hours. It should be immediate, it should be obvious, and there should be no catastrophic event in the device failure. So what are the drawbacks of the presently available closure devices? Cost, yes, is a drawback. There is some increased local inflammation and pain. Infection is rare but more with collagen-based products. Reaccess issues,
You
foot
have
plate
2 minutes,
devices,
please, to wind up. Thank you.
foot plate devices, and obviously there's a learning curve. So I would like to conclude by telling you that always plan your closure before you take an access. It is always better if we plan our closure before we have an access. The decision regarding a closure device is complex and depends on many factors, so I would request that you please individualize the risk-benefit ratio, and when the risks are high, please use a closure device. There is still insufficient data from randomized controlled trials, but you should use the one with which you are best comfortable with and with which you have had the maximum experience. Thank you.
Thank you very much. We have 1.5 minutes for questions, please. So you can address your question to Dr. Agarwal. 1.5 minutes, please.
Hang on. I enjoyed that presentation very much. Which do you prefer, something that leaves something in the vessel or something that leaves nothing behind?
Sir, I would rather not leave anything inside the vessel, and being a vascular surgeon myself, I personally would go for a suture-based device.
Okay.
Dr. Anurag, when we do the EVAR or TVAR, the minimum size of the hole in the artery is 18 French. Can we put the 2 devices?
You can use 3 proglides at the same time, in fact. They have said that you can put them one on top, one after the other, in the same hole, and start deploying one device after another. So you can close this thing sequentially like you do in suturing.
But do you not think that open surgical procedure, putting a stitches or the closure of the arteriotomy by putting the protein stitches is more superior than putting 3 devices?
It decreases the hospital stay. It improves the patient comfort. It is a total percutaneous procedure, and the patient can go home the same day if you want.
Okay, thank you.
Yes, sir. Is there a flow mic available somewhere?
Yes, sir.
There is one behind you.
It was very interesting to hear you because it's unusual to have such a presentation. But I would like to advise that this kind of procedure need a learning curve, as you've told. There is a high cost, so you need to have a high volume in your center, so you reduce the median cost. And I would like to stress the fact that you must not use this sort of device in very calcified lesion, because sometimes you can push a plaque and put your anchor between the plaque and the vessel wall.
Yes.
This could be very bad at the end. And the second contraindication, in my opinion, is microartery. In a small woman, for instance, the anchor with angel seal, for instance, can induce artificial stenosis that could be that could worsen the situation. It was just a comment. Thank you anyway.
Thank you, sir. Sir, actually, the IFUs also do not recommend usage in sizes below 5 millimeters in diameter. Vessels in 5 millimeters diameter. Lesser than that, it is not recommended. It is not recommended in vessels with high calcification and erythematous plaques.
So we have the same opinion. Thank
Yes,
you.
sir. Thank you, sir.
Thank you.